Thank you, and thank you for the invitation as usual. This will definitely keep you up, so brace yourself. These are my disclosures. The only one really that's relevant is the book that we have on LASIK emergencies published by Slack. I have a very tiny financial interest in that. So I'll present you a few scenarios that are truly nightmares. The beauty of having a fellowship is teaching, of course, but more beautiful than that is being able to collect cases like these to present at conferences. But most importantly is that you can blame your complications on your fellows. And sometimes as you're teaching, like here, as the fellows start, they're typically a bit more gentle than you want them to be. And such in this case where the fellow's trying to lift this flap and there is a sticky spot. So you're watching on the screen and then you just come and whisper in their ear, just grab a little forceps and pull a little bit, and they're being gentle, justifiably so, but you just have, you're being too gentle. Just lift and grab it from another side, and it will just come, and you're just wondering, shall I take over at this point or no? And you're like, okay, see, I told you, you just have to be a little bit more forceful and it'll be just fine. And then you go on to a different case on a different day, and everything is going pretty well, and you get to the point where it's like really sticky, and you tell the fellow, I told you, you're being too gentle, and I just want to flip back a little bit here to show you what happened. As you pull down on a flap that's maybe a little bit too thin, watch on the hinge level, and boom, you get this tear. So this looks like a nightmare, and it is a nightmare at that point, but as long as the flap is not free, you just lift, watch the bed, and if the bed is good, you can just go ahead and treat, and these patients will do okay. And of course, on occasion, you have other sticky situations such as this one, where the side cut is not as cut as you'd like it to be, and pulling may tear the flap. So don't be concerned about just grabbing a Vaness scissor and cutting. This is a really clean cut and works very nicely, especially when it's on the side of the flap. But for these cases, it was pretty clear that things were sticky, but sometimes they're not. And look at this case. You see this line here? It looks pretty innocuous, especially after you applanate. There's nothing really unusual going on. Everything is proceeding as expected. Even when the pass goes through, this is normal here, but when you had this oblique line, there was nothing really to alert you that something was going to happen. But as you're dissecting the flap, watch here in the middle. There is a sticky point, and bang, right through the center of the flap. So the question is, do I lift? Do I not lift? Well, you lift and you take a look, and if the bed looks okay, it's fine to treat. How do we know that? Because I've encountered some situations where I had patients who come with trauma to their flap like this one, and this is an injury. This is kind of a flap within the flap, and you see this cut right in the middle, very close to the visual axis. So basically, clean any epithelial ingrowth, take any epithelium of the surface of that fold there, because there was some folds to flatten it, and then you put everything back in place. And surprisingly, after you put everything back together, these patients end up with very good vision despite having a cut here. So as long as the cut is clean and not ragged, typically these cuts in the visual axis do not affect vision. And this is the last case of nightmare number 4, where flap folds end up with a domino effect. And that is with an epithelial ingrowth, DLK, and a persistent defect. This is a case I had early in my career. So typically when you have folds, you can either lift and just try to iron the flap, but sometimes you have to debride the epithelium because epithelial hyperplasia. Why does that happen? Because the cornea recognizes an irregularity and starts forming all these epithelial cells that go into the creases, and the flap becomes very sticky. So what you need to do is an epidefect. You need to create an epidefect to debride the epithelium and allow the flap to be flattened. So here you remove the epithelium and you see all these folds. So this will allow you to flatten the flap. But in that case, what happened is that when you have an epidefect, the next thing that can happen is DLK. So we had to float the flap one more time. And then after that, we had an epidefect. And this epidefect was at day 5, day 15, day 25, day 45. Yes, it's a nightmare. And I can tell you we tried everything to treat that patient, from plugs to lubrication to everything. And then finally we said, well, maybe there is an ingrowth under this flap that's preventing it from healing. So we decided to lift the flap. And so lifted this flap, and actually the interface is pretty clean. And I'm thinking, okay, well, there's only one thing that we have not done to this flap is suturing it. So why don't we just do that? So we placed sutures all around to tack this flap down. And surprisingly, the flap's starting to heal. And the only way we could think about that is that now the flap was tacked down, it wasn't edematous anymore, and we started seeing the healing over the suture area where you had the little dip. And this patient ended up 2020, but at day 73, it was a true nightmare. This is the book I mentioned, and sorry to spoil your afternoon, and thank you for having me.
Thank you very much, Samir. So Terry, what about mitomycin C? Can you tell us how much you use and how do you use it so that the delegates can learn from it?
Sure, I think mitomycin C is a very helpful adjunct in these cases where you have an increased risk for scarring. So for instance, some of the cases that Samir showed certainly are nightmares, and you have to keep in mind that sometimes you may have to go to a flap amputation. And if you look at some of the case series, they visually do very well, but in cases like this, you do want to use mitomycin C. Typically, I use 0.02% and put it on the bed for about 30 seconds and make sure I irrigate it off. Same thing for PRK. As we know, Randy Epstein and Parag Majumdar published that if you do 75 microns of ablation, it helps to have the mitomycin C to prevent scar tissue. But honestly, I use it for all my PRK cases, because if you see some of the low myops that are treated with PRK, you'll still get this subclinical reticular haze. So I think it's a very safe adjunct, and it's really key to prevent that scar tissue, because much rather to prevent it than treat it afterwards.